Hi, and welcome to Healthcare IT Today. This is Colin Hung, and today I'm joined by Dr. Jay LaBine, who is CMO over at naviHealth. Dr. LaBine, welcome to the program.
Thanks, Colin. Thanks for having me.
Now, we were just chit-chatting before we started that you actually hail from a few miles from the Canadian border, which is where I'm from.
You betcha. You betcha there, Colin.
I'm detecting the Minnesota accent, is that right?
Yeah, I grew up in northern Minnesota, about 60 miles from Canada and about 40 miles from North Dakota.
Nice. And now you're saying that you were telling me that you find yourself in Nashville a lot.
Yeah. So I've been at naviHealth for 2 years, and the naviHealth corporate headquarters are in Nashville, Tennessee, and Brentwood, actually.
I love Nashville. It's a great city. I love obviously love the downtown core there, but just love the people there too. Just so much history and the musicians and everything. It's a fantastic place to be.
Yeah, there's a lot of energy. I actually bought a place in a up and coming area of Nashville called the Gulch. I get teased a lot that I'm too hip for the rest of the team.
That's awesome. That's awesome. Well, again, thank you for joining me on the program today. We're going to dive into transitions in care, which is a topic that you are definitely very passionate about, and that's the area that naviHealth plays. So let me start by asking you this question. Transitioning from acute care to a long-term care facility, I mean, we've been doing this for years and years, haven't we?
Oh yeah. It's actually been a challenge. Handoffs in the medical community have always been a challenge. It's like handing off from either one facility to another, but also one caregiver, one physician to another. Handoffs are where a lot of things can, get disrupted and be fragmented.
And why is that transition so broken? I mean, we've had years to address this, but why is it like the way it is?
Yeah, so it's a complicated transition, right? And the first thing I'll have to say is that even pre-COVID, we knew there was going to be challenges in the transition. COVID has made this even worse. And think about this too, Colin, is that COVID has caused disruption to the entire society, but healthcare has had a lot of disruption from COVID. Um, and the care transition specifically, but the people who are transitioning are those that are generally frail, elderly. They're the ones that are being selected to go to a facility, right? And in that facility, that's where they're going to get their rehabilitation care. So you're already sub-selecting a population that's really frail and this is actually where COVID's had its worst effect. We know that preferentially there's more deaths in the frail elderly with chronic comorbidities. So it's even more complex now.
So maybe can you give me an example of some of the challenges and the problems that are happening in this transition from one facility to another in particular?
Yeah, so when the care transition ends up being one that Medicare has decided that patient choice is really important. So the first part of the care transition is what's the most appropriate next level of care setting for that individual and who makes that determination, right? So at naviHealth, we work with customers, hospitals, and health plans to help put more rigor around that choice. Like, what is the most appropriate next setting of care? And we have a proprietary care planning tool that uses data. And Colin, this is a really important point about the data we input is the functional condition of that patient versus other types of data, which would be like their primary diagnosis. Is it a heart failure patient or a COPD patient? Well, they're actually going to the transition to get functional care or rehabilitation care. So the first part of this is understanding what is the next best setting of care and bringing more data to make that decision.
And who is responsible for fixing this? I mean, who is the person that is looking after these transitions? Is there an owner in the hospital or an owner in the facility that's receiving this patient?
Yeah, so there is not one company or one role or one person who is responsible for fixing the care transition, right? naviHealth has actually brought a lot of their data and technology to like make it more seamless, but it's always been a problem with how can you make the right decision. Remember this, Colin, is that if I've worked in a hospital as a, let's say, a discharge planner or a physician, a hospitalist, for my entire career, I've rarely set foot into a skilled nursing facility, so I have no idea like where I'm sending this person.
True enough. True enough.
But the hospital is like saying, you need to send this person out because we need another bed. So it ends up being a really process that people that are making the decisions need help with that decision making. So fixing that next first level of care that's most appropriate is part of what we bring to the table, but it's also something that can be done universally in the system by helping the hospital become more responsible for that next level of care health outcome.
So if I was a CEO, or maybe more appropriately a CIO at a hospital,
Right.
what would you say to me to convince me to dedicate resources to solving this problem now? And I mean, when I say now, I mean in the context of the pandemic, like right at this moment. What would you say to me?
So what I would say is that we've started to make some progress in making hospitals responsible for the next level of care, right? Many hospital CEOs, right, take this very seriously because it's a value driver, it's a patient satisfier, and that seamless experience for their patients is a good value proposition for a CEO, right? And more, integrated care means keeping them within your system so that you can ensure that these handoffs are seamless. So two really important things for a CEO are, let's maximize the patient experience so you have patient loyalty. And secondly, you can get better outcomes for your patients, which will help with your value proposition as a healthcare provider.
Okay, where do I sign? Where do I sign the check?
There you go. Right.
I'm sure we all wish it was that easy, right?
Yeah. It really is difficult, Colin, because our payment model isn't set up to really incentivize that yet. So we're making baby steps. I'll give you one example, right? Is hospitals in the past weren't responsible or accountable for readmissions back into their hospital. But over the last few years, the hospital, payment program, which is a value-based program that penalizes hospitals that have high readmissions, well, that has really spurred more attention. I think we just aren't doing enough of that. I think we need to do more.
Well, I guess that's where the thrust of my question was going. It just seems that there's no true owner of this problem. I mean, the hospital does seem to own a little bit more now because they are responsible, as you just said, for the readmission issue.
Yeah.
But there's no one that seems to be responsible for the actual transition of care, unless they're in a very, very large system where the facility I'm transferring to is also my own, right? And so I wonder if that's part of the reason why this hasn't been addressed, yet it's been a problem for so long.
Yeah, and these handoffs have been a problem. It's actually one of the value propositions that we're trying to bring to the healthcare system. kind of like talking with people like you to say, it's really important to do this well. And I think the pandemic has shed a light on this even more. And I'm hopeful in some ways, Colin, that just like telehealth got adopted in the pandemic, like at an amazing rate, like it went like from 0 to 60 in 2 weeks. You're pretty familiar.
I'm laughing with you
Yeah.
because you're absolutely right. We went from almost, the curve was the hockey stick that we, the kind of good hockey stick that we want to see in terms of adoption, right?
It's a good hockey stick. I think the same thing could happen with care transitions. We could have a hockey stick effect by saying, are we meeting the needs for these frail elders that are, and what are those needs? Like, what do they really feel is important? So one thing that I think we need to recognize is that people don't generally go to a facility for their rehabilitation after a hospital by choice. They have to go there. And they feel like there's much more desire from seniors to really age in place. They want to be home. In fact, many organizations, including ours, is tracking days at home. Like, can we give you more days at home? So to meet the needs or the desires of this population, we should understand that they don't really want to be there. They have to be there. So let's try and get them back to full function so they can go home.
Well, you bring up a good sort of wrinkle that's been thrown into us. I certainly agree with you that COVID has highlighted the vulnerability of this frail population.
Yeah.
But we also now have this new element of care at home. So no longer are we just transitioning to skilled nursing facilities and long-term care facilities, but I'm presuming that we're transitioning a lot of patients to at-home care or back to their home. Does that add a new complication to this transition?
I say it adds an opportunity for the transition. And this is where I was making the reference that I'm hopeful that we could, accelerate some of these solutions that pre-COVID we knew actually worked, but the adoption or the financing just wasn't there. I'll give you one example that's really relevant is there's a population of the most high acuity patients. Like, these are very frail elderly, like 95 to 99. Colin, I remember when there weren't that many 99 and 100-year-olds to take care of. But now they're really common. In fact, by 2050, according to the Kaiser Family Foundation, the number of 100-year-olds and 90-year-olds will quadruple in the United States.
Wow.
We need some new solutions. Well, one solution that we've worked on in pockets is this home-based care, like a house calls, a house calls program. And I think that has a lot of opportunity to say, hey, if I can just transition you to a physician who will see you in your home and take care of you, I don't need to send you to a facility.
Right. So, I know you're very, very, or I hear, and I'm getting the sense that you're very, very passionate about senior care.
Yeah.
Given what's happened with COVID, and again, how it has exposed the vulnerability of where we house them, how we treat them, how we transition them, what do you think has been the one thing that coming out of COVID we definitely need to address?
So I would say, first of all, to recognize that a lot of these challenges in care transitions in senior care were present pre-COVID and not urgently addressed, right? And the second thing would be what we just talked about is let's engage with innovation. And I'd say the third thing would be we need to invest more in the care model. I talk about, you asked like how would I, as a CEO of a hospital, like invest in the care model? I think we also need others to invest, whether it be private industry, whether it be philanthropy, whether it be government, like investing more of the Medicare dollar into the care transition. But that care model, we saw with COVID, Colin, that there was inadequate testing, access to testing, there was inadequate PPE, inadequate investment into the workforce. I think we need to really invest in that care model.
That actually was going to be my next question. What has to happen from this point forward in your mind to fix this transition problem and to fix the problems with moving patients from one facility to the next?
Yeah, so the first thing is that investment in the care model.
Okay.
But then the second thing, and this is like important for all of healthcare, but I think it's particularly important here, is transparency. So we should have more transparency into the outcomes that occur in a building, in a facility, the experience that occurs there, and actually the cost that it takes to do that. If we could have transparency in that, it would lead to more competition and more improvement overall. Like, and you know this, but in COVID, they did mandate that you had to report your COVID cases. Before that, there was no mandate to report that. So I think transparency is really important. And the last thing is, we touched on it a little bit, Colin, is we need to engage more in innovation, like engage in those other care models. It won't be adequate for everybody, meaning we still will need facility-based care for the transition, but I think we could do a lot more to provide those kinds of clinical services in the home so that a portion of people won't have to go to the facility.
I love it. Those are really good steps that we could take to move forward. Now we just have to sign those into law, right?
Yeah, well, yeah, right. Let's take a top-down approach, right?
There you go. Let's just sign it into being.
I think we could get the government to agree, right? We could get Democrats and Republicans to agree.
Oh yeah, that's pretty easy, right? I mean,
that's pretty easy. Yeah, no problem.
So let me ask this, Dr. LaBine. What is naviHealth doing down the road to help solve this problem?
Well, we really are on the forefront of the care transition problem, and it's been a problem for a long time, like I said. And there's great variability in the outcomes in post-acute care. It's really the most highly variable part of the care cycle, of the care journey of a patient. So naviHealth is working with large health plans and with large health systems and physician groups to work and provide a concierge-like service that allows patients to understand better what's happening to them as they move from the hospital into the skilled nursing facility. We actually have clinicians in hundreds of skilled nursing facilities that work with patients and families and the facility to ensure a smooth and good patient experience, and then they discharge to home. We use this care planning tool that gives you a benchmark, and we can grade how well you're doing to the best practice benchmark. Putting that, and then when a person goes home, we got to make sure that they can do the things that we're asking them to do, meaning, can I dress myself? Can I button my blouse? Can I button my shirt? Can I toilet myself, right? Can I walk a block? Because that's what you're going to be asked to do when you get home. And we got to know that. So that's really important. naviHealth does that for our customers on a very large scale.
Final question, Dr. LaBine. Where can people go to find more information about naviHealth?
Yeah, they can get us at navihealth.com and look there for more information. Perfect.
Well, thank you so much for taking the time today. This has been wonderful. I've enjoyed the conversation, transition from one facility to another. I can't believe it's still broken after so many years. But hopefully with companies like yours, that will start to be addressed in the near future.
Yeah, I really appreciate the conversation. Thanks a lot, Colin.
This has been Colin Hung with Healthcare IT Today with Dr. Jay LaBine from naviHealth. Thanks for listening.